Welcome to Group 11's project, A Comprehensive Ethical Approach to Clinical Integration of Radiological Artificial Intelligence presentation, where we conducted a non-systematic review of the technical, ethical, and legal issues surrounding the use of AI in clinical radiology. Next slide. Artificial intelligence has had a transformative effect on many fields of clinical healthcare. An especially impacted domain is medical imaging, with machine learning systems now applied to the interpretation of radiological images at scale. It is used to diagnose, detect, localize, and prognosticate diseases, as well as for reconstruction of MRI and other medical imaging applications. Deep learning algorithms, convolutional neural networks, and generative adversarial networks significantly improve the accuracy and efficiency of medical image analysis, ultimately delivering better outcomes for patients. However, these high-performing models offer no intelligible account of how they reach the conclusion. And in a medical setting, this challenges the public trust, while the stakes when mistakes are made are much higher than in other typical software deployments. For this project, we examined the ethical landscape surrounding AI in radiology, assessing the regulatory environment, the documented biases and past failures, and current advancements to find solutions. We then provided recommendations for how to reform the system equitably. Ajay will now discuss the technical review.
Hi, this is the review of the modern AI landscape in radiology. Here are the major categories of applications in modern radiological AI. As you see, it's a family of different models that spans a large amount of applications, from pneumonia detection to using gene data to predict your trajectory to assisting staff and workflow. However, with such vast implementation, there has been serious constraints. Papers such as the hidden stratification and Murad showed models have limited flexibility and the black box nature is susceptible to hallucinations. These have severe consequences in the medical field. There are some efforts being made to explain reasoning, like XAI with GradCam and SHAP, but these efforts to create saliency maps and feature attributions are only approximating and is not an actual interpretation of what's going on inside the model, which creates an illusion of transparency, and the problems from before can still arise. Constraints are also compounded from the fact that there is no universal oversight. Regulation differs from region to region, which is something developers can capitalize on and by following the most lax frameworks. But exposure will only be on implementing clinicians in the current model.
Next, we'll talk about the recommendations for clinical integration for radiological artificial intelligence. Next slide, please. These were the guiding principles we had while talking about our technologies: promote well-being and minimize harm, respect human rights, dignity, and privacy, maximize transparency and dependability, human accountability above all. Next slide. So these are the two different types of validations we can do. We have static validation and dynamic validation and reliability. In static validation, the model is evaluated for performance at a fixed point of time. It scales with study, that is one of its strengths. It's a proposed grading system and the debasing to enforce fairness across subgroups. In dynamic validation, you treat AI deployment as a coupled dynamical system with feedback, which might look like AI outputs to radiologist behavior, downstream decisions, future data distributions, but it does require continuous monitoring across sections for operational signals. Next slide, please. And looking at static validation, we might ask the question like, hey, in typical clinical settings, we have grading criteria based on that is evidence-based, but for radiological AI, there is no framework that exists. So a radiologist looking at an FDA-cleared AI tool has no standard way to ask like, hey, how rigorously was this validated? Was it tested in one hospital or 200? Is it on old scan or is it accounted for new scans because technology moves? So what we are proposing is the table on the right-hand side is this would be similar to clinical evidence and AI validation type be coupled together. For example, if one of them is like if you start at the top, it'll be the weakest one. So useful for proof of concept, but limited by institutional bias and constrained by historical data sets. If you move towards the middle, you would have the prospective validation in clinical workflows. The system gets evaluated in real time with real patients and under real workflow pressure, so it is much more robust. And the final one we recommend is ongoing layer. The post-deployment monitoring, the function of the AI is equivalent to a post-market surveillance in drug regulations. Next slide.
Okay, so this slide introduces the core idea behind the framework, which is that AI development is a feedback loop. The clinical environment determines what gets imaged and how scanner protocols, patient demographics, disease prevalence, and workflow conditions are affected. This produces the imaging input, which the AI model processes to generate an output. The radiologist responds to that output and then may accept it, override it, flag it, or modify the report. Those responses influence downstream clinical decisions like biopsy, discharge, follow-up imaging, or treatment. Those downstream decisions then change the future clinical environment itself. So AI does not just analyze healthcare systems, it actively changes the future data distributions the system will later encounter. Next slide. To monitor deployment safely, we track both technical signals like calibration drift and predictive degradation, and human-centered signals like override frequency and workflow fatigue. Next slide. Perturbations are small real-world disturbances like scanner noise, demographic shifts, or protocol variation. We measure how sensitive both the model outputs and explanation systems are to those perturbations because the model can have stable predictions and unstable explanations, or vice versa. Next slide. If instability is detected, governance responses are triggered. Things like recalibration, additional review, or retraining. These governance responses are human interventions, and so they are potentially intensive. The challenge is balancing safety with workflow efficiency because every intervention also creates operational burden for humans. Next slide. This introduces the idea of the acceptable operating region. The system continuously evaluates whether that state vector, S sub t, is within the acceptability bounds. If it is, then we're good. If it penetrates that boundary, then we need to induce a governance response. Next slide. So this helps to visualize this control loop, bringing the whole monitoring architecture together. External perturbations continuously affect the development environment. While operational signals track system behavior over time. The controller integrates those signals and sends them to the acceptability module, which does math and checks if that state is in that acceptability region or not. If it is, then the state evolves. If it isn't, then a governance response is induced and the state evolves as well. The whole point is the perturbations build up over time. They don't just like one perturbation doesn't send the system out of control. Next slide. So this is a projective. So because it's technically a 7-dimensional space, we need to project it to visualize it appropriately. So we can see how the deployments that exist in this multidimensional space made up of signals like the predictive performance, calibration, etc. Each panel is essentially a different projection of the same acceptable operating region. As perturbations accumulate, that path moves and moves and moves until it hits the border, then the governance response is induced, sending the signals back to safety. Okay, this also shows why calibration matters. Depending on the dimensions of each thing, how this space is constructed, that will determine what is rate limiting. So even one poorly calibrated signal can result in a highly rate limited control system. Next slide. This is just another visualization. Here we do it with a boundary. So instead of the 2D projections, we kind of just make it a line, a surface that's advancing over time until it hits the boundary. Next slide. And then here we can just see with just choosing 2, we can see how different acceptability regions produce different geometries. Next slide. And then here we compare different governance functions. So in those previous assumptions, visualizations, we were assuming we did not modify the governance response. That was constant. Here we're showing how different governance responses could lead to different magnitudes of response or severities depending on the kind of regime we choose. Next slide. We also have to acknowledge there's certain limitations to these models. The static validation assumes that we have static data, cross-training, and deployment. And the dynamic model assumes that we have all these metrics and they're integrated into a single system, as well as the control theoretic formalism assumes Markov structure. The common limitation is both frameworks assume the monitoring system remains reliable regardless. Okay, next slide.
Current radiological AI regulation remains fragmented across jurisdictions, creating inconsistent safety standards and opportunities for regulatory arbitrage. We recommend moving towards harmonized international frameworks that establish a shared minimum floor for validation, transparency, and accountability. Liability should also be more clearly defined, with responsibility shared proportionally across developers, deployers, and clinicians, rather than placed solely on physicians. Finally, because AI systems evolve over time, regulation must become adaptive through continuous post-market monitoring, defined revalidation thresholds, and clear escalation pathways when performance drift or bias emerges. And I'll leave the next slide to Viva.
So the ethical integration of artificial intelligence into radiology requires not only the technical reliability, but reliability and regulatory oversight, but also the sustainable incorporation into clinical workflow. So here what you're seeing in this diagram is the radiologist-centered AI workflow designed for safe and ethical integration of AI in radiology. The main idea is that AI acts only as a support system, while the radiologists still remain the primary decision makers throughout the process. So the workflow begins with the image inputs like CT scan, X-rays, or MRIs, and AI system may first assist by prioritizing the urgent case, or if there is any high risk in the data. So if there is an high risk, it will be escalated to radiologists. Then they perform the interpretations, while the AI tools can just support the tasks such as lesion detection, segmentation, measurements, etc. So, however, these AI inputs, AI outputs, whatever we get, are only assistive and not the independent. We are not relying on them. So, when there is any uncertainty or any possible instability in the system triggers conditional escalations. In such cases, human review is very much important, and so the final interpretation and sign off always remains with the radiologist. So a dynamic deployment controller continuously monitors the systems and adjusts thresholds and escalates the workflows when at risk. So overall, it ensures the balance between efficiency, safety, accountability, and ethical AI use. Next slide, please. This slide explains how human oversight changes depending on clinical task and risk level. So the table explains it. The main idea here is that the oversight should scale the risk, meaning the low risk task can use more automation, while the high risk cases need stronger human involvement. So if AI outputs are unstable or if there is any mandatory radiologist review or escalation required, human intervention is very much important over there. So overall, this framework ensures efficient use of AI while keeping patient safety and accountability at the center. Next slide, please. Another main ethical consideration is fairness and equity in AI systems. So these systems must perform reliably across all patient groups, including the underrepresented populations. So if training data is not diverse, the model may perform poorly for certain demographics, leading to unequal outcomes. Therefore, training data sets should be representative and inclusive of all the subgroups or the all the populations with all the groups of people. So federated learning helps address this by allowing institutions to collaboratively improve models without sharing sensitive patient data. So this supports both fairness and privacy in healthcare AI systems. Next.
Thank you for listening to us. We do have a few Q&A prepared that might have come up, so we'll go through those. The first one is going to be, what does the FDA's 510(k) pathway actually mean, and why is it important? It is the most common FDA approval process for medical devices. And so what happens instead of running a new clinical trial, a company essentially shows that their device is substantially equivalent to one already on the market. About 97% of the radiology AI tools actually get cleared this way. The concern is that substantially equivalent is not the same as rigorously tested, especially for AI systems, and they might behave very differently from older devices. The next question we have is, have any of these AI tools caused harm to a patient's life? So we'll take a look at the COVID-19 example. During COVID-19, researchers reviewed over 400 AI models to detect disease from chest x-rays alone and found that none were reliable for clinical use. So in this case, harm is less often a dramatic case and more a pattern of tools getting deployed